This is my undergraduate thesis presentation on the effects of microprocessor-controlled knees on the progression and development of knee osteoarthritis in individuals with unilateral transfemoral amputation, a literature review, and supplementary data analysis. The structure of this presentation will follow that of the paper with intro, methods, results, discussion, conclusion. Jumping right into the introduction. First, I will go over what unilateral transfemoral amputation is, along with some of the current prosthetic technologies available to patients, and one of the primary conditions affecting these patients, knee osteoarthritis, which will lead us into the objectives of this study. With respect to unilateral transfemoral amputation, or UTFA, first I'll discuss the definition, and then some common causes and some relevant outcomes with respect to the condition. Transfemoral amputation is defined as the removal of the lower leg by cutting through the thigh tissue and femoral bone. And in this context, unilateral means that only one leg is amputated. However, both sides are affected, with the amputated side being referred to as ipsilateral and the non-amputated being referred to as contralateral. With respect to the causes of UTFA, the most common ones include vascular conditions, whether that being due to peripheral arterial disease or diabetes-related issues. Trauma is also another common cause, which is, of course, variable, whether due to incidents with heavy machinery or combat-related injury. Periprosthetic joint infection is another cause that is a little bit less well-known, wherein the prosthetic joint of a total joint arthroplasty becomes infected, and after multiple failed salvage attempts of the joint, amputation can become necessary. Cancer can also necessitate amputation in cases of bone cancer or skeletal metastases. There are many outcomes to UTFA. However, this study will focus primarily on mobility level outcomes via K levels and then musculoskeletal health outcomes. So generally, patients are prescribed a K level ranging from 0 to 4, with K0 patients being incapable of mobilization on a prosthesis, K1 patients being household ambulators, K2 patients being limited community ambulators, K3 patients being more capable community ambulators, and K4 patients being those capable of activities that exceed basic ambulation skills typical of a child or athlete. With respect to musculoskeletal health outcomes, this patient population in general is more likely to develop secondary musculoskeletal conditions, namely knee osteoarthritis. However, the distinction of this risk between mobility levels is relatively unexplored in the literature. This brings us to the current prosthetic technologies available to these patients, which include primarily mechanical and microprocessor-controlled knees, in addition to some powered options as well commercially. With respect to microprocessor-controlled knees, the general functionality of these devices are to provide real-time response to sensor input via the modulation of joint resistance, and this is supported in a variety of tasks, including standard walking, but also things like stair and ramp navigation, in addition to any specific modes of the device, like cycling or golf mode. The primary actuation methods of the flexion and extension of the joint where this resistance is applied include hydraulic, pneumatic, hybrid control, and magnetorheological systems, where hybrid control are those that combine hydraulic and pneumatic components, while magnetorheological systems rely on the magnetic fluid within the joint, which when magnetized can create resistance, as is with the Rio knee seen here on the right. Additionally, these devices, of course, come equipped with various sensors. All commercial modern MPKs, typically containing a IMU, or inertial measurement unit, typically placed within the thigh or shank of the device, which helps to orient the device spatially. Additionally, a knee angle and knee moment sensor in conjunction with an axial load sensor are often present, and together these help to determine the dynamic conditions present to inform the control algorithm of the device. And the control algorithms of commercial MPKs are generally consistent and can be categorized into two main functionalities: the walking controller and the intent recognition, where the walking controller is generally governed by a finite state machine, or a system that breaks the gait cycle into a finite number of states and transitions between those states based on the thresholding of sensory information. With respect to intent recognition, this is the method by which these devices switch between user modes, and this is governed by a heuristic rule-based approach, which is again based on the thresholding of sensory information and is typically meant to be robust and unambiguous to prevent incidental mode activation. With respect to prescriptions and coverage, these devices have typically been prescribed to K3 and K4 level patients. However, recent legislation has encouraged the prescription to K2 patients, given the research backing increased stability and reduced fall risk associated with device use. This brings us to the next segment of information relevant to this study, which is knee osteoarthritis. So as per the Arthritis Foundation, knee osteoarthritis is a degenerative joint disease that can affect various tissues within the knee joint, including cartilage, fat, bone, and synovial tissue, as well as ligaments within the joint. This can degrade cartilage and change bone shape, as well as lead to inflammation. Common symptoms of the condition include pain, stiffness, and a loss of mobility, and this condition already affects over 32.5 million U.S. adults and is the most common form of arthritis. With respect to the variables that can exert some influence over disease development, there are those that are considered modifiable risk factors and those that are non-modifiable, in addition to some comorbidities for the condition. Those that are modifiable include primarily those that relate to mechanical stresses being placed on the joint, in addition to some potential dietary and metabolic influences. Mechanical stresses primarily relate to things like obesity, physical activity levels, occupational factors, and biomechanics, while dietary and metabolic influences can also relate to things like obesity and overall health. Additionally, there are some non-modifiable risk factors which primarily relate to that risk generally increases with age and female gender, while ethnicity and genetics also are supposed to play a role. Additionally, there are several comorbidities for knee osteoarthritis, and that those include primarily these listed here: diabetes, hypertension, cardiovascular disease, renal failure, gastrointestinal bleeding, depression, and/or physical impairment, including obesity. All of this brings us to the objectives of this study, which, considering the elevated rates of knee osteoarthritis in the unilateral transfemoral amputation population, it is possible that the current prosthetic technologies available to them, i.e. MPKs, could play a role in that relationship. Therefore, this study aims to determine the effects of MPKs on knee OA development in this patient population. The study hypothesizes, therefore, that this relationship is heavily dependent on unique patient and device characteristics, from which stratification between these things could provide a greater understanding of the relationships at play. Therefore, the literature review aims to establish the current understanding of patient-device outcomes and differentiate devices, while the data analysis seeks to differentiate patient groups biomechanically, specifically K2 and K3 patients. This brings us to the methods of the study, which include those of the literature review and the data analysis. Those of the literature review included a search of relevant databases with relevant search terms, including but not limited to knee osteoarthritis, transfemoral amputation, and microprocessor-controlled knees. With respect to the data analysis, the methods of this involve those of the study from which the data was taken, which was a publicly available dataset of 18 patients with UTFA. This study utilized marker-based motion capture along with a split belt treadmill and instrumented force plates, splitting participants into two mobility level groups, K2 and K3 patients, 9 per group. With respect to the extraction of this data, kinetics and kinematics were both considered. For kinetics, the last trial of each specified walking speed was utilized to ensure the participant was sufficiently warmed up, while for kinematics, the reference study normalized the sagittal ankle, knee, and hip angles to a single stride per walking speed. These trials were then input into a custom-developed MATLAB program from which values were extracted. These were taken with respect to the population average self-selected speeds for the K2 and K3 population, or the trials that were closest to the average self-selected walking speed for those populations, in addition to matched speed trials to consider the influence of walking speed. The output of these This program can be seen here for kinetics and kinematics, which we will dive a bit deeper into later. And you can also see the equations on the top right for the peak vertical ground reaction forces of the vertical, propulsive, and braking peaks. And additionally, the calculation to equate the difference between these of the contralateral and ipsilateral limb. And finally, the equation for the symmetry indices of the ankle, knee, and hip. This brings us to the results of this study, which again include those of the literature review and the data analysis. With respect to the literature review, first an analysis of knee osteoarthritis and UTFA was considered, with the general understanding of microprocessor-controlled knees following that. With respect to knee OA and UTFA cases, it was found that there were several related conditions in addition to several potential influences of prosthetic ambulation. With respect to related conditions, several were identified between patient groups, including lower back pain, hip osteoarthritis, and bone spurs being prevalent between both patient groups. Additionally, osteoporosis was a condition that related to both patient groups, in that UTFA patients typically present with lower bone mineral density consistent with osteoporosis in the residual limb, which is likely induced by disuse atrophy, potentially suggesting compensatory loading on the contralateral limb, while knee OA cases typically have an inverse relationship to osteoporosis. Additionally, diabetes is important to consider, as it is a large comorbidity for knee osteoarthritis and a large cause of transfemoral amputation. It is also important to consider the potential influence of prosthetic ambulation on the relationship of knee osteoarthritis in UTFA cases. Therefore, first, we will look at asymmetries associated with prosthetic ambulation. Typically, patients present with a skeletal malalignment, which can affect lower body kinetics and kinematics. This often presents in the sagittal plane through things like asymmetrical ankle, knee, and hip angles. Additionally, this can be identified in the frontal plane through pelvic orientation, where both UTFA patients and knee osteoarthritis patients typically exhibit greater pelvic inclination. Additionally, lumbar lordosis is an asymmetry that is common to UTFA patients, wherein they typically possess greater lordosis or bending of the lower back, while knee OA cases typically present with less lordosis. Proprioception is additionally, of course, impaired by amputation, which can affect gait stability and gait coordination. Additionally, the decline of proprioception with age was found to be a factor of influence with respect to the increasing risk factor of age with respect to knee osteoarthritis. Additional limb length discrepancy is a variable that plays some influence with respect to asymmetries, since it can lead to some asymmetrical patterns, despite that it is often intentionally facilitated to create toe clearance. Therefore, given these asymmetries, it is important to consider them in their role with respect to adverse loading in prosthetic ambulation. It is also important to consider the inefficiencies associated with prosthetic ambulation, one of which being the increased metabolic cost associated with prosthetic ambulation, in addition to the decreased walking speed and stability, with studies suggesting that a patient is more unstable the more joints are missing. Additionally, stance time is inefficient in prosthetic ambulation typically, given that the contralateral limb typically has greater stance time compared to the ipsilateral. Additionally, hip flexion contractures contribute to gait inefficiency, as they are common in UTFA patients, and they typically can hinder hip extensor power as well as general gait efficiency. Muscle strength imbalances are also common in that the ipsilateral is typically weaker than the contralateral, which can exacerbate some asymmetries and create things like lateral trunk lead, and can also, again, limit efficiency. Therefore, these inefficiencies can exacerbate existing asymmetries, and also the increased metabolic costs associated with prosthetic ambulation could be sufficiently high to elevate reactive oxygen species in patients, therefore increasing the level of inflammatory mediators associated with knee osteoarthritis. Finally, it is also important to consider the loading patterns associated with prosthetic ambulation, and these include those of static standing, walking, and double limb stance. So when standing, patients typically load their intact limb more, and that increases upon balance perturbation. When walking, this continues where the contralateral limb experiences greater loading in especially the vertical and anterior posterior planes. Additionally, several studies have considered double limb stance, wherein this persists either when leading with the ipsilateral or contralateral limb. Greater forces were observed for the contralateral, and all of these discrepancies tend to scale with ambulation speed. Therefore, given these loading patterns in conjunction with the asymmetrical and inefficient gait of patients, it is likely that prosthetic ambulation plays a role in the degeneration of patient musculoskeletal health. This leads us into the literature review on microprocessor-controlled knees, which first aim to differentiate them from traditional mechanical knees and then differentiate between them. With respect to the differentiation of microprocessor to mechanical knees, there were several benefits identified in the literature that were more so undisputed and some that were a little bit more contentious between studies. Those that were undisputed included benefits to daily living, user preference, safety, and some marginal improvements to gait efficiency through improvements to metabolic expenditure. Those that were contentious were primarily related to biomechanics, specifically kinetics and kinematics. Several studies found improved gait smoothness kinematically, while some studies also found improved kinetics through the transition of the knee moment from hyperextension to an adequate amount of flexion at heel strike, which was cited by another study as potentially reducing the risk of OA by 60% in this population. However, this was contrasted by a similar number of studies that found no kinematic or kinetic improvements, some finding the persistence of sagittal asymmetries in the ankle, knee, and hip, as well as no transition of that knee flexion moment, or no change in the contralateral loading patterns, especially in the vertical and anterior-posterior planes. Given this, it is useful to differentiate these devices to determine whether or not the influence may be related to differences in device type. When doing so, we see that there are some philosophies in device design that best elucidate the benefits of microprocessor knee use. Those include primarily a single method of actuation, with hybrid systems exhibiting some discontinuities. Additionally, complete microprocessor control is essential, as the lack of extension resistance in some manually adjustable pneumatics can limit adaptability. Additionally, intelligent control algorithms further improve the outcomes of microprocessor-controlled knee acquisition, given that pre-stance resistance can improve fall prevention and pre-stance flexion can improve symmetry and overall kinetics, as well as kinematics. The outcomes of this optimal system include further improvements to daily living and safety, with some more consistent findings of metabolic expenditure, being that all devices were around the same improvement to metabolic expenditure. Additionally, there were some improvements to symmetry from the optimal microprocessor knee system, including more symmetrical knee flexion and some reduced contralateral loading, specifically with respect to stair navigation. This takes us to the results of the data analysis, which included the population-based self-selected speeds and match speed trials. At population-based self-selected speeds, there were several significant differences in kinetics as well as kinematics. Those that were observed kinetically were greater peak vertical, propulsive, and braking ground reaction forces, as well as a greater peak differential braking ground reaction force, those all being greater for the K3 group. And with respect to kinematics, the mean and peak sagittal knee angle symmetry indices were greater for the K2 group, indicating more asymmetry. At match speeds, this kinetic influence shifted, wherein the peak vertical ground reaction forces remained greater for the K3 group, while the other kinetic influences were no longer significant, and the peak differential vertical ground reaction force became significant as being greater in the K2 group, indicating greater kinetic asymmetry at match speeds. With respect to kinematics, the peak knee symmetry indices remain greater for the K2 group. This brings us to the discussion of all these results, which first we will discuss patient outcomes. It is likely that the higher incidence rates of knee osteoarthritis are being driven by these adverse gait parameters in conjunction with the concurrent conditions between UTFA and knee OA patient populations. And while the etiology of amputation is relevant to this, given that secondary conditions occur across amputation etiologies and are prevalent in younger patients, it is probable that prosthetic ambulation plays a role. The asymmetrical and increased loading of the contralateral side meets the definition of adverse mechanical loading, while the inefficiencies associated with prosthetic ambulation are potentially able to elevate oxidative stress and therefore inflammatory mediators associated with NEOA, exacerbating issues. However, given the variability between patients in this population, it is useful to define differences, which was the purpose of the supplementary data analysis, from which, as we discussed previously, there were several things that were consistent between participants and several that were statistically significant between patient groups. Those can be seen here, and we will dive a bit deeper into them here, where the ipsilateral propulsion of patients was typically decreased compared to the contralateral. This could likely be attributed to the consistency between ankle devices, wherein the mechanical energy return of the ankle device could not meet the push-off power of the intact limb. This can be observed in the anterior-posterior ground reaction force plot here, where the yellow contralateral peaks visually exceed those of the blue ipsilateral. With respect to kinematics, there were also consistencies with respect to ankle and hip asymmetry, both being common to all participants. The primary contributor to ankle asymmetry being a lack of prosthetic plantar flexion at toe-off, as is with a mechanical carbon fiber knee. This can be observed in the left plot here of the ankle angle, where at around 70% of the gait cycle, there is a large dip in the contralateral ankle angle and no change in the ipsilateral, which was the major contributor to ankle asymmetry and was consistent between participants as a result. With respect to hip asymmetry, this was also common between participants and could typically be attributed to a lack of contralateral hip extension. So as you can see in the hip angle plot on the right, the red contralateral hip angle did not quite reach that of the ipsilateral, and this was consistent between participants and has been associated with altered knee joint mechanics, suggesting universally altered knee joint mechanics between the patient population that was in this study. With respect to statistically significant differences, there were some found for kinematics in the sagittal knee angle. So the peak knee symmetry indices were greater in the K2 group, indicating more asymmetry, and the contributor to this asymmetry was, however, consistent between patient groups, where the contralateral peak knee flexion was later than the ipsilateral, indicating increased stance time on the contralateral limb, and also the ipsilateral peak knee flexion was less than the contralateral, indicating reduced ipsilateral knee flexion of the prosthetic. This can be observed in the two plots seen here of the knee angle, with the left representing the median K2 symmetry indice and the right plot indicating the median K3 indice, where the contributors to asymmetry are the same, but more severe for the K2 participant, where you can see visibly the contralateral limb in red follows the ipsilateral by a significant margin, and it also reaches a greater degree of flexion, therefore contributing to a large rise in the symmetry indice. This can also be observed for the K3 graph on the right, however, being slightly less severe. With respect to the kinetics, there were some differences at self-selected speeds. However, their disappearance at match speeds likely indicates they could be attributed to the increased walking speed of the K3 participants. However, at match speeds, there were some significant differences that persisted, including that the peak vertical ground reaction forces were greater in the K3 group, while the differential between the contralateral and ipsilateral limb of the peak vertical ground reaction forces was greater in the K2 group. This indicates greater loading for the K3 participants, with more kinetic asymmetry for the K2 participants. This can be seen in the vertical ground reaction force plot here of a K2 participant, where the black contralateral peaks significantly exceed those of the blue ipsilateral. All of this together shows that the supplementary data analysis corroborated several previous findings, including increased contralateral loading and stance time, along with reduced ipsilateral swing flexion and contralateral hip extension. This data analysis also found some new differences between patient groups, such as that K2 participants typically exhibit greater kinetic and kinematic asymmetry, while K3 patients experience greater loading overall due to their increased walking speed on average. Together, these suggest that Both patient groups are at significant risk of musculoskeletal health implications due to prosthetic ambulation and the adverse gait parameters typically associated with it. However, the distinction between the risk of mobility levels is difficult to quantify given the lack of data on the population. However, currently the prosthetic landscape is certainly more lacking for lower mobility participants like K2 patients. With respect to microprocessor-controlled knee acquisition, it was found that while MPKs offer clear advantages in terms of user confidence and fall prevention, they are limited in their scope to address biomechanical issues due to high variability within the patient population and between device types. Therefore, stratification between these things could provide greater understanding. Upon stratification, it was found that MPKs can marginally improve some biomechanical outcomes, but these are typically limited to more optimized device types and higher level mobility patients. Therefore, they are not comprehensively addressing these issues, nor are they addressing them for all patients. Therefore, while MPKs have the potential to reduce knee OA risk, benefits are not comprehensive or guaranteed for all users, underscoring the need for more tailored prosthetic solutions, as well as more inclusive prosthetic solutions to optimize outcomes. With respect to some of the potential future directions to improve upon this, there are some promising avenues for improvement, including optimized control through things like machine learning controllers or neural interfaces. Additionally, powered systems have the potential to reduce metabolic costs associated with prosthetic ambulation, and improved prescription could improve patient outcomes by better characterizing these patients, and collecting more data on these patients could also improve understanding of biomechanical relationships to device use. There are also some important limitations to consider with respect to this study. Those of the literature review, of course, include those of the reference studies, of which some contain some small sample sizes and some potential biases with respect to laboratory settings or devices, differences in study design, including acclimation time differences, device use history differences, in addition to high in-group variability for the patients being evaluated. Additionally, some microprocessor knee studies especially have a potential conflict of interest given the funding of the study with respect to device manufacturers. Additionally, the data analysis had some important limitations in that the sample size was relatively limited considering the number of demographic variables that could have also influenced results. However, these variables were assumed to be a function of mobility level, therefore they would be either affected by or affect mobility level prescription. Additionally, the study was limited in its scope to address some biomechanical outcomes such as medial lateral ground reaction forces or joint moments, and it only considered sagittal plane kinematics. Additionally, the use of handrails was a potential confounding influence for some of the findings of the study, as there were available handrails for participants, which were primarily used on the match speed of the K2 participant trials. Therefore, those could have confounded some results. In conclusion, although microprocessor knees provide robust benefits with respect to overall safety and user preference, they are limited in their scope to address biomechanical issues, as demonstrated by the persistence of adverse gait parameters across mobility levels, especially when considering the data analysis. Around 89% of participants utilized a microprocessor-controlled knee, and there was persistence of several adverse gait parameters in that analysis. Upon stratification, higher-level ambulators with more optimized device types are most likely to benefit from the marginal improvements provided by MPKs to biomechanical outcomes. Consequently, MPKs have the potential to reduce the risk of knee osteoarthritis in certain cases, but these are dependent on patient characteristics and device types, and thus not guaranteed for all users. Therefore, more inclusive and effective prosthetic solutions must be developed to address these issues. Then these are some of the references utilized, or all of the references utilized in this presentation with respect to the images. Those of the paper can be found in the reference section of the actual paper. I would now like to open the floor to any questions. Thank you very much.